Welcome back to the deep dive. Now, if you're a GP trainee deep in prep, maybe with that AKT exam looming large, well, this deep dive is definitely for you. We're tackling a really critical area today. Allergy, angioedema, and anaphylaxis. We got a bunch of sources, and we're aiming to pull out the key protocols, the distinctions, the stuff you really need to know.
Absolutely. And this isn't just, textbook stuff. These are real clinical scenarios you'll face. Fast decisions, knowing the right drug, the right dose. It's crucial.
Couldn't agree more. So our mission today is to unpack all this, really focus on those practical details, especially drug management, which is, let's face it, vital for the exam and for safe practice.
Yeah, exactly. Things like telling IgE from non-IgE reactions quickly, knowing the adrenaline dose is cold, that kind of thing.
Okay, let's unpack this then, starting right at the beginning. Foundational definitions. A patient comes in, they've had a reaction. First hurdle. Is it an allergy or an intolerance? What's the absolute core difference according to the sources?
It boils down to one thing: the immune system. An allergy is defined as an immunological response. Your immune system reacts to something, an allergen. And because the immune system's involved...
That's where the danger lies.
Precisely. That's where the potential for anaphylaxis comes in. The body basically overreacts, treats something harmless like a major threat.
Okay, so immune system involvement equals allergy, but take that classic example. Someone drinks loads of milk, gets awful stomach cramps, diarrhea, but it's not their immune system attacking.
That's your intolerance. The sources are clear. Intolerance is non-immunological. Like lactose intolerance, you just lack the enzyme lactase to digest the milk sugar properly.
So it feels bad, maybe really bad, but it doesn't have that same immediate life threat pathway.
Generally, no. It doesn't involve that same immune cascade leading to anaphylaxis. And clinically, that makes a huge difference in how urgently you need to intervene, right?
Absolutely. Okay, that distinction's clear. Now, what about this term atopy? It crops up a lot. Is it an allergy itself or something else?
It's more like the tendency, the predisposition. Atopy is defined as a genetic or familial leaning towards developing allergic diseases. Things like allergic rhinitis, asthma, eczema.
Ah, so it's like a flag. If you see atopy in the notes, you should be thinking higher risk for allergies.
Exactly. Your allergy antenna should definitely twitch.
Right.
It means this person or their family is sort of biologically primed to potentially develop allergies, maybe even severe ones.
Right, the fertile ground idea. Makes sense. Okay, let's dive into food allergy. Super common in GP land. And the sources really stress splitting them into two types based on the mechanism, because that dictates everything: speed, symptoms, risk. We've got IgE-mediated and non-IgE-mediated. Let's start with the fast one, the scary one, IgE.
Right. IgE-mediated is your classic immediate reaction. The key word is speed. It happens fast, seconds, minutes usually.
And why so fast?
Because it uses these preformed IgE antibodies. They're already stuck onto mast cells, just waiting. When the allergen turns up, bang, they trigger this massive instant release of histamine and other chemicals.
And it's not just like a rash in one place, it goes everywhere.
That's the danger. It's systemic. You get multi-system involvement very quickly. Skin flares up hives, itching, respiratory tract gets hit, wheezing, coughing, shortness of breath, gut reacts, vomiting. And crucially, the cardiovascular system can be affected. Blood pressure drops, potential shock.
So quick onset, multi-system, potentially life-threatening, that's IgE.
That's IgE in a nutshell, high risk.
Okay, now contrast that with non-IgE-mediated food allergy. This one seems trickier to diagnose sometimes because it's delayed.
Much more delayed. Here, the reaction isn't driven by those instant IgE antibodies. It involves other immune cells, T cells mostly, and mobilizing those takes time.
How much time are we talking?
It can be hours, sometimes even a day or two after eating the food. And the sources highlight this as seen way more often in infants and younger kids.
And the symptoms are different too, not that sudden multi-system explosion.
Yeah. Exactly. It's much more focused usually on the gastrointestinal system. Think chronic or recurrent stuff. Really bad vomiting, nasty cramps, maybe mucus in the poo, loose stools, that sort of thing.
Sounds miserable and obviously worrying if it affects growth, but not that immediate airway or circulation crisis.
Generally, no. The acute life threat isn't typically there like it is with IgE. It's a different kind of problem, often needing careful dietary management rather than an EpiPen.
Right, let's make that concrete. Baby tries formula for the first time. 5 minutes later, covered in hives, wheezing, vomiting, That's
IgE, no question.
Yep.
Emergency, adrenaline needed.
Okay, same baby, tries the formula, seems fine. But 3-4 hours later, starts screaming with tummy pain, has horrible diarrhea, just miserable for hours, that sounds like.
That points much more towards a delayed non-IgE reaction. likely cow's milk allergy in that scenario. Needs sorting diet-wise, not resuscitation.
Yeah.
Getting that timing difference is absolutely core for your AKT prep and practice.
Definitely. Okay, wrapping up this section. Common culprits, the foods we need to be most aware of.
The sources flag a few consistently, especially cow's milk, eggs, peanuts, and shellfish. Those seem to be the big ones to keep in mind. Peanuts and shellfish often causing those severe IG reactions that can last into adulthood.
And risk factors. We mention antipy as the general predisposition. What are the top 2 specific things in a patient's history or presentation that really increase their odds of developing a food allergy?
2 key ones highlighted are atopic eczema, especially moderate to severe eczema, and a family history of allergy or atopy.
The eczema link is interesting. How does that work?
The thinking is that a damaged skin barrier in eczema lets allergens get in through the skin first. The body gets sensitized that way, and then when the person eats the food later, boom, you get the allergic reaction. So significant eczema should always make you think about potential food allergies.
Okay, so we suspect an IgE reaction is happening. We need to know exactly what to look for, those multi-system signs. Let's break down that presentation in detail, starting with the skin.
All right, the skin is often the first thing you notice. You're looking for urticaria, those classic hives, raised, red, intensely itchy patches that appear really quickly.
Mm-hmm.
Then there's general itching, sometimes just feeling fleshed all over flushing. And, importantly, angioedema.
That's the deeper swelling.
Exactly. Swelling of tissues under the skin, lips, eyelids, tongue, sometimes hands and feet. It looks quite dramatic.
But a crucial point you mentioned earlier, you can have anaphylaxis without the skin signs.
Yes, absolutely.
Yep.
Up to 20% of severe cases might not have obvious hives or angioedema, especially if their circulation has collapsed quickly, pulling blood away from the skin. So don't rely solely on skin signs.
Good point. Okay, next system, respiratory. This feels like where the immediate danger often lies.
It certainly can be. You're listening for wheeze, that tight chest sound from bronchospasm. A persistent cough can be a sign too.
And what might the patient report?
They might say they feel really short of breath, SOB. Or that terrifying sensation of their throat closing up that's laryngeal edema, swelling in the voice box area. Even things like lots of sneezing or a suddenly blocked nose can be part of it, showing the mucous membranes are reacting.
So any respiratory symptom really ramps up the concern level.
Definitely. Much higher level of vigilance needed than for just skin symptoms alone.
Got it. Moving to the GI system, how does that present in an acute IgE reaction?
Again, it's usually rapid and quite severe. Sudden onset abdominal pain, often described as cramping, maybe sudden forceful vomiting, and intense nausea. Much faster and more dramatic than the delayed non-IgE stuff.
And finally, the really ominous one, cardiovascular CV signs. This means shock, right?
Yes, this indicates systemic shock. The release of all those inflammatory chemicals causes blood vessels to widen massively and become leaky. Fluid pours out of the circulation,
Leading to
hypotension, low blood pressure, the definition of shock. Initially, the body tries to compensate, so you often see tachycardia, a really fast heart rate.
But that compensation can fail.
Yes, particularly in severe cases or sometimes in children, the heart can't keep up. And you might actually see bradycardia, a slow heart rate, which is a very worrying sign, potentially pre-arrest. Any sign of circulatory compromise is basically the definition of severe anaphylaxis.
Okay, grim picture, but essential to recognize. So, we've seen the signs. How do we actually diagnose this in primary care, assuming the patient isn't acutely unwell right now? What's the assessment pathway?
Well, assuming they're stable, it starts with history, history, history. A really detailed food diary is invaluable. What did they eat? Exactly when? What happened? And when did that happen?
Trying to link cause and effect.
Precisely. That often leads into an elimination trial, carefully removing the suspected food to see if the symptoms actually stop. That's your foundation before you even think about tests.
Right. And if that points towards a specific food, then we consider specific testing. What are the main options?
2 main IgE tests are used. First, the skin prick test, SPT. You put tiny amounts of different allergens on the skin, make a small prick, and measure the reaction of the wheal and flare after about 15 minutes.
Okay.
And the other is a blood test, serum-specific IgE testing. This actually measures the amount of specific IgE antibodies to different foods circulating in the blood.
Now, this next bit seems absolutely crucial, potential AKT question territory. The sources stress a caveat about both these tests. They're described as specific, but not sensitive. What does that mean in practice?
Yeah, this trips people up. Specific means if the test is positive, it's quite likely real. It confirms sensitization, the presence of those IgE antibodies. High specificity means few false negatives for the sensitization itself.
Okay.
But the lack of sensitivity for clinical allergy is the problem. It means you can get false positives. The test is positive, showing sensitization, but the person can actually eat the food without any reaction. The test detects the antibody, but it doesn't guarantee a clinical reaction will happen.
So a positive test doesn't automatically equal a clinical allergy.
Exactly. It indicates risk or likelihood, maybe high likelihood, but you must correlate it with the patient's actual history. If the history is rock solid for a reaction, a negative test might be a false negative. If the history is weak but the test is positive, you treat the history, not just the test result.
That's a really important nuance. So given this potential ambiguity, when do we need to say, okay, this needs specialist assessment and refer for a supervised food challenge in a hospital?
Two main situations. Firstly, if the diagnosis is uncertain, maybe the history and the tests don't match up or the elimination trial wasn't clear-cut, a formal challenge is the gold standard then.
And the second?
Secondly, and this is very common especially with kids, is to check if they've outgrown the allergy.
Mm.
Many childhood allergies, particularly milk and egg, resolve over time. A supervised food challenge is the only safe way to prove they can now tolerate the food so you can liberalize their diet again. You wouldn't do that outside a hospital setting.
Makes sense. And for someone with a confirmed allergy, what are the cornerstones of management?
Number one is strict food avoidance of the confirmed allergen. That's paramount. But because removing foods, especially major ones, can impact nutrition.
You need expert help.
Yes, input from a dietitian is usually essential, particularly for growing children, to make sure they're getting enough protein, calcium, calories, all the essentials. And for mild symptoms, if they occur, antihistamines can be used for relief.
Right, let's apply this, a really common GP scenario. Managing a baby with suspected cow's milk allergy, CMA. How does the approach differ based on feeding? Let's start with a breastfed baby.
Okay, if the baby is exclusively breastfed, the allergenic cow's milk proteins are coming through the mother's milk. So the first step is for the mother to completely eliminate all dairy from her own diet, rigorously.
And is that it? Just mom avoids dairy?
No, and this is a key point, often missed, very relevant for exams and practice. If mom is cutting out dairy, she's cutting out her main source of calcium and often vitamin D. So you need to prescribe vitamin D and calcium supplements for the mother, protect her bone health.
Ah, good point. Okay, what about the bottle-fed baby? Can't just take mom off dairy then.
No. For a bottle-fed infant with CMA, you need to switch the formula. The usual first step is to try an extensively hydrolyzed formula, EHF.
What does hydrolyzed mean here?
It means the cow's milk proteins have been broken down into much smaller pieces, peptides, which the baby's immune system is much less likely to recognize and react to. Most babies with CMA do well on EHF.
And if that doesn't work, if the baby still has symptoms on EHF?
Then you escalate. In that small percentage, maybe 5–10% of cases, you move to an amino acid formula, AAF. Here, the protein is broken down completely into its basic building blocks, the amino acids. That's the least allergenic option available.
Okay, clear pathway. Now, regardless of whether it's CMA or another allergy, when do we absolutely have to refer a child to secondary care? What are those clear referral criteria?
There are definite red flags. Number one, any history of a severe allergic reaction or actual anaphylaxis. If they needed adrenaline or had significant breathing or circulation problems, they need specialist assessment.
Makes sense. What else?
Significant comorbidities. The big one here is moderate to severe asthma. Having both allergy and poorly controlled asthma is a major risk factor for very severe, even fatal, reactions. That combination needs specialist management.
Right. And the third main reason?
Any other worries, particularly faltering growth. If the allergy or the dietary restrictions needed to manage it are impacting the child's growth, you need pediatric and specialist dietetic input urgently.
Okay, faltering growth is a definite trigger for referral. That leads nicely into talking about angioedema more specifically. We mentioned it as a sign, but let's define it properly.
Sure. Angioedema is that swelling deep in the skin or mucous membranes. So deep dermis, subcutaneous tissue, submucosa. Clinically, you see it as swelling of the lips, around the eyes, the tongue, sometimes hands, feet, even genitals.
And usually with hives and allergic reactions.
Often, yes, it occurs alongside urticaria in allergic cases, but it can happen on its own. The sources describe it as generally less severe than full anaphylaxis, but it can still be acute and worrying, especially if the tongue or throat is involved.
Now, the really important bit for GPs causes, it's not always allergy, is it? What's the big non-allergic cause we must think about?
This is critical. Yes, allergic reaction is common, but you absolutely have to consider non-allergic drug reactions. The classic culprit is ACE inhibitor-induced angioedema. Think ramipril, lisinopril.
And why is that different?
Because the mechanism isn't IgE or histamine. It's thought to be mediated by bradykinin buildup. And crucially, because the mechanism is different, it doesn't respond to the usual allergy treatments like adrenaline or antihistamines. And it can happen even months or years after starting the drug. Sometimes it's idiopathic too, no clear cause found.
So identifying that ACE inhibitor link is vital because the treatment approach changes. Let's contrast the management. Acute severe angioedema, say, tongue swelling, difficulty swallowing versus stable, maybe just lips.
Okay? Acute severe, especially with any hint of airway compromise, tongue swelling, voice change, stridor, that's an immediate admission to hospital, no question. Airway monitoring is key.
And treatment in hospital.
Treatment is parenteral IV or IM. We're talking IM-IV, chlorpheniramine, an antihistamine, and IM-IV hydrocortisone, a steroid. Focus is on stopping the process and protecting the airway.
Right. Now, what about the stable patient? Maybe they come to the surgery, lips are a bit swollen, maybe hands too, but breathing's fine, voice is normal.
If they're truly stable, airway's clear, vital signs okay, they may not need admission. First step is remove the cause if known, stop the ACE inhibitor, avoid the allergen.
And treatment.
Treatment can usually be oral, so an oral antihistamine, maybe a short course of an oral steroid, but because they're going home, clear safety netting instructions are absolutely non-negotiable. They need to know exactly what worsening signs mean. They need to come back immediately or call 999. Things like throat tightness, difficulty breathing, voice change.
That safety netting sounds critical for outpatient management. Okay, now we get to the sharp end, the highest stakes. Anaphylaxis management. This isn't just about knowing stuff, it's about having a drilled protocol.
Absolutely. Anaphylaxis is the definition of a medical emergency. Key features:
Right.
rapid onset and progression. And it hits multiple systems, typically airway, breathing, circulation, often with skin or mucosal signs too. Recognizing it fast is everything.
Let's lock down those really critical presentation cues. What are the absolute danger signs that scream anaphylaxis?
Okay, by system.
Any stridor, that high-pitched noise on breathing in, hoarseness, where the patient's saying their throat feels like it's closing up, that's laryngeal edema.
Breathing.
Respiratory, severe wheeze, looking exhausted from the effort of breathing. Cyanosis, blueness, or low oxygen, so that's clear hypoxia.
Circulation.
Circulatory, signs of shock, feeling faint, collapsing, persistent hypotension, low BP, or sometimes that severe tachycardia we mentioned earlier, or even bradycardia.
And neurological.
Neurological, sudden confusion or agitation. That suggests the brain isn't getting enough oxygen due to poor circulation. And yes, you might see the urticaria or angioedema, which helps confirm it's likely allergic, but you manage the ABCs first, regardless.
Okay, clear danger signs. The response needs to be immediate and structured. What's the absolute first step, the framework?
It has to be the ABCDE approach. Airway, breathing, circulation, disability, neurostatus, exposure, look for clues, remove trigger. That's your mental checklist.
And immediate actions alongside that.
Yes. Try to remove the trigger if obvious and safe. Stop the IV drug, brush off the insect sting, get high-flow oxygen on immediately 15 liters via a non-rebreather mask if possible. But the single most important life-saving intervention is
adrenaline.
Without delay.
Right, let's focus hard on adrenaline dosing. This has to be second nature. We're talking adrenaline 1 in 1,000 concentration, given IM, intramuscular, usually into the mid-outer thigh, vastus lateralis. Let's get those doses crystal clear.
Okay, memorize these. For adults and children over 12 years, it's 0.5 milligrams, which is 0.5 milliliters of the 1 in 1,000 solution.
0.5 me for over 12s.
Got it. For children aged 6 to 12 years, it's 0.3 milligrams, which is 0.3 milliliters.
0.3 mil for 6 to 12s. Okay.
And for children under 6 years, it's 0.15 milligrams, which is 0.15 milliliters.
0.15 mil for under 6s. So 0.5, 0.3, 0.15 milliliters of 1 in 1,000 given IM.
Exactly. Those doses are critical. And IM is crucial because it gives rapid, reliable absorption.
Now, the sources make a point about IV adrenaline. Why is that basically off limits outside of a hospital expert-led resuscitation setting?
Because 5e adrenaline is potent and potentially dangerous if given incorrectly or in the wrong situation. Giving it 5e carries a much higher risk of causing severe side effects like dangerous heart rhythms, arrhythmias, critically high blood pressure, hypertension, or even heart muscle damage, myocardial ischemia.
It's much riskier than IM.
Far riskier in the initial management phase, outside of critical care with full monitoring. IM is the standard, safe, effective first-line route for anaphylaxis. 4 is reserved for refractory cases or cardiac arrest by experienced teams.
Okay, adrenaline is in, oxygen is on, ABCDE approach is running. What comes next? The adjunctive treatment to support the resuscitation.
Right. You've given the lifesaver, now you support the system. Anaphylaxis causes massive vasodilation and leaky capillaries, so patients lose fluid from their circulation. They need volume replacement.
Fluids.
Yes, an IV fluid challenge. Large volumes of crystalloid solution, like saline, given quickly to try and restore circulating volume and blood pressure.
And then the other drugs, antihistamines, steroids.
Yes, after the initial ABCs and adrenaline are sorted, you give the secondary medications, typically 5-E chlorpheniramine, the antihistamine, and IV hydrocortisone, the steroid.
Now, the timing here seems important. The sources list hydrocortisone after the main resuscitation. Why wait? Steroids are anti-inflammatory, aren't they?
They are, but their effect isn't immediate. Adrenaline works in seconds to constrict blood vessels, open airways, stop mast cell degranulation. Hydrocortisone takes hours to start working properly because it acts on gene transcription.
Ah, so it's not for the immediate crisis reversal.
No. It's given primarily to help prevent a potential biphasic reaction. That's where symptoms can come back hours later after initially improving, and to dampen down the overall inflammatory process longer term. Adrenaline saves the life now. Steroids help prevent relapse later.
Got it. Priority is adrenaline and fluids. What about persistent symptoms like wheeze?
If wheeze or shortness of breath isn't fully relieved by adrenaline, you can add inhaled bronchodilators, usually salbutamol via a nebulizer or spacer. Treat the remaining symptoms.
And throughout all this?
Continuous monitoring. Reassess ABCDE constantly. Check vital signs frequently. Heart rate, BP, oxygen sats, respiratory rate, ECG monitoring is needed. And be prepared to repeat the IM adrenaline dose every 5-15 minutes if the patient isn't improving or deteriorates again.
Okay, intensive management. Let's shift to after the crisis. What follow-up is absolutely essential for anyone who's had anaphylaxis.
This is non-negotiable. Every single patient needs referral to an allergy specialist. They need proper investigation to confirm the trigger and comprehensive education on avoidance and future management.
And what should they leave with, prescription-wise?
They must be prescribed adrenaline autoinjectors. And critically, they need 2x adrenaline injections.
Why 2?
Several reasons. The first dose might not be enough. The reaction could be severe or biphasic. There might be a problem using the first device. Having 2 provides a backup and the option for a second dose if needed after 5-15 minutes.
Makes perfect sense. Anything else?
We should strongly consider advising them to wear an advisory bracelet or necklace or carry a medical alert card, something that clearly states their allergy and that they carry adrenaline. It can be life-saving if they collapse and can't communicate.
Wow, okay. That was a huge amount, but absolutely vital stuff. Let's try and quickly recap the key take-homes. We started with the fundamental difference. Allergy is immune-mediated, carrying risk. Intolerance isn't.
Then we split food allergy into IgE fast, multi-system, high risk, and non-IgE delayed, mainly GI, common in infants. Knowing the difference is key for initial assessment.
We detailed the presentation skin, respiratory GI, and the critical CV signs of shock, and highlighted that IgE testing is specific but not perfectly sensitive, so history is king, and sometimes you need that supervised food challenge.
Yep. We covered cow's milk allergy management, remembering the vitamin D and calcium for breastfeeding moms and the need to refer for severe reactions, comorbidities like asthma or faltering growth.
Then angioedema, remembering it's not always allergic, watch out for ACE inhibitors in tailoring management. Admit and use IVM for severe, consider oral treatment and strong safety netting for stable cases.
And finally, anaphylaxis. ABCDE first, immediate IM adrenaline, 1 in 1,000, knowing those doses. 0.5 milligrams, 12 wires, 0.3 milligrams, 6 12 wires, 0.15 milligrams, 6 wires, followed by oxygen, IV fluids, and then the adjunctive antihistamine and hydrocortisone. Repeat adrenaline if needed.
And crucial follow-up. Specialist referral, prescribing 2 autoinjectors, and considering medical jewelry.
Exactly. So thinking about this for your practice, for the AKT, we know adrenaline is the immediate lifesaver for that circulatory collapse and anaphylaxis. That catecholamine effect is key.
Right, it buys you time.
It does. But think about why the guidelines consistently include hydrocortisone given after resuscitation efforts. We know it takes hours to really kick in, so it's not reversing the acute shock.
So what is its main job then, beyond just general anti-inflammatory effect?
Well, that leads to the provocative thought. Given its delayed action, what specific longer-term risk is hydrocortisone primarily aimed at preventing after that initial adrenaline-dependent emergency has been managed? Think about that phenomenon of symptoms recurring hours later, the biphasic reaction. Understanding that risk helps clarify why we give steroids even though they don't work immediately on the initial crisis. Something to mull over.
A really important point to consider for consolidating that knowledge. Fantastic. Thank you for walking us through all that complexity. That was incredibly useful.
My pleasure. I hope it helps everyone listening with their prep. Good luck.